Okay, thank you. I'm sharing my slides, just one moment. So I am Marco Zecca, and I'm a physician, and I'm mainly involved in allogeneic stem cell transplantation in non-malignant disorders such as hemoglobinopathies and especially sickle cell anemia. And I have prepared some slides for a brief talk of about 10 minutes, 15 minutes, no more, just to give you an idea of what a stem cell transplant is and the results, the current results of the procedure, as well as the possible problems and the difficulties. So as we know, an allogeneic stem cell transplantation is a quite complex procedure. I have tried to summarize it in this slide, and the aim of an allogeneic hematopoietic stem cell transplantation is the replacement of the patient defective hematopoietic cells with healthy hematopoietic cells from a healthy donor. So this procedure can be, this aim can be achieved using a so-called conditioning regimen, that is a combination of different chemotherapy drugs, and in some selected cases also of radiotherapy that are necessary in order to do what is called marrow ablation. Marrow ablation is a condition that we have to achieve. We have to destroy all the stem cells present in the bone marrow of the recipient in order to allow the engraftment of the donor cells. So this is the conditioning regimen. Then we have a healthy donor that can donate either bone marrow cells or peripheral blood stem cells. And the availability of a donor is regulated by a set of genes, so-called human leukocyte antigens, that regulate the compatibility between a patient, recipient, and his donor. Usually the best donor is a donor who is 100% compatible with the recipient. This means that the HLA typing, these human leukocyte antigens of the donor, are identical to the human leukocyte antigens of the recipient, of the patient. Today, this statement is not true anymore, because we know that we can perform the transplant also from a donor who is not 100% compatible with the recipient. There are specific techniques that allow this procedure. It is a little bit different procedure, a little bit different transplant, but today, and I will present you the data, we can do the transplant also from a partially matched family donor. So we have the donor, we have the patient, we give to the patient the conditioning regimen, this chemotherapy that usually lasts from 5 to 7 days. And after the chemotherapy administration, we have the transplant, the infusion of the stem cells collected from the donor, the infusion to the recipient using a central venous line. The stem cells are infused intravenously, and then we have a post-transplant period that is an important period. We can experience some complications. We have to wait for the engraftment, but during this period between the infusion of the stem cells and the engraftment, that usually lasts between 12 to 4 weeks, patients can have infections, can experience toxicity from the conditioning regimen, and can have hemorrhagic complications. So this period of so-called aplasia between the infusion of the stem cells and the engraftment of the stem cells is very important. And usually the patients stay in the hospital for the transplant for a median of 30 to 45 days. And then if everything goes well, patients are discharged. We follow them in our outpatient unit at the beginning twice weekly, and then after 2 or 3 months, once weekly, and then the frequency of the controls in the outpatient unit decreases. So if this is a general picture of the transplant procedure, we must start from the donor. So the best donor is a so-called matched family donor. What means matched family donor? Is a brother or sister, a sibling, who is HLA identical to the recipient. A donor can be also a carrier of sickle cell anemia, an heterozygous subject, an heterozygous sibling. This is a good donor as well. And the identity of the HLA typing makes it a perfect donor. Unfortunately, the probability of having a matched family donor is quite low, because the probability that two siblings are HLA identical is just 25%. So in the majority of cases, we have to search for a matched unrelated donor. In all countries worldwide, there are registries of voluntary stem cell donors that are willing to donate. So if we don't have a matched family donor within the family, matched an HLA identical sibling, we can start the search of a matched unrelated donor worldwide. Again, it is not so easy to find a matched unrelated donor, because again, we must have a very good degree of compatibility between the donor and the recipient, if possible 100% compatibility. So unfortunately, so far, in the majority of cases, it was not possible for children or adolescents or young adults affected by sickle cell anemia to go to the transplant because of the lack of a matched donor, of a compatible donor. More recently, several techniques have been developed in order to be able to perform the transplant also using a partially matched family donor. What does partially matched family donor means? It means a family donor, usually the father or the mother, if we are talking about pediatric patient, about children, or a partially matched brother or sister. And in this case, a specific approach has been developed in order to allow the transplant also from a donor that is compatible just for 50%, let's say, of the HLA antigens I was talking some minutes ago. This approach of a transplant from a partially matched family donor is so-called haploidentical transplant. That means a transplant from a donor who is 50% compatible. Is not recent. It was developed several years ago, initially for patients affected by leukemia, and over time the results improved significantly, and nowadays, and I will show you the results, we know that a transplant from a haploidentical donor, a transplant from a partially matched family donor, can give results that are superimposable to that of a matched unrelated donor. The technique to perform the transplant is slightly different, but the results are really similar, and I will show you them. The next point, this is a difficult slide, but just to give you an idea of this topic. We have, as I said before, with the transplant, we need to achieve the engraftment of the donor cells. Nevertheless, we don't need to achieve 100% donor engraftment in the transplants for sickle cell anemia or for thalassaemia or hemoglobinopathies in general. we know that also a partial engraftment of the donor cells can be sufficient to completely cure the disease. And this is very important because the possibility to cure sickle cell anemia also with a partial but stable over time engraftment of donor cells allows us to use a conditioning regimen, a combination of chemotherapy before the transplant that is less intensive, and this means also less toxic with less side effects than the conditioning regimen that we usually use, for example, for leukemia. So in a condition such as sickle cell anemia, it is not necessary. Of course, it is better if you can achieve a 100% donor engraftment, but it is not necessary to obtain a 100% donor engraftment. Also a 50 or 60, 70% donor engraftment is enough to cure the disease. And this allows us to use a less intensive and less toxic conditioning regimen. And this is an important point. So, which is the state of the art? As I said, if we had a matched sibling donor, a 100% sibling donor, the results of the transplant are very good. These are two very big studies, including more than 1,000 patients, that can show you that the probability of survival and event-free survival after transplant from a matched sibling donor are between, the probability of cure is between 90 and 100%. We know that age of the patient is important. In fact, as you can see here, if children are transplanted from a matched sibling donor when they are younger than 5 years of age, in this study, the authors reported a survival probability of 100%, but the survival probability progressively decreases with the increasing age of the patient. It is 95% for children and young adolescents, and it is a little bit less than 90% with adolescents or young adults. This is the state of the art from matched unrelated donors, so for transplants performed from a donor outside the family. And again, in this case, the most important factor for a good result is the degree, the level of compatibility between donor and recipient. As you can see, if you have a donor that is 100% compatible, he is 10 out of 10 HLA antigens identical, we have a probability of survival in the order of more than 95%. But the probability of survival decreases if we have a donor that is not 100% compatible. So an open problem with matched and related donor transplants is that the probability of finding a 100% compatible donor is not so high. In some cases, is less than 50 or less than 20%. So this first transplant from a family donor can be applied only in the minority of patients who have a matched family donor, a brother, a sibling, a matched sibling, and that the probability of finding a matched unrelated donor is not very high in several cases. So this just to summarize this first part of the presentation. Where do we stand now with the stem cell transplant for sickle cell anemia? We know that we have a very good disease-free survival, a very good probability of complete cure if the transplant is performed with a matched family donor, more than 95% probability of complete cure. And we know that we have a low transplant-related mortality. Nevertheless, if we move from a matched family donor, from a matched sibling transplant to a matched unrelated donor transplant, we have a higher rejection rate, especially if we use a donor who is not 100% compatible. But the good news is that we don't need to achieve a 100% chimerism. to cure the disease. Also a stable mixed chimerism, a mixed chimerism that is stable over time, can cure the disease. So what do we need now? We need to be able to offer an early stem cell transplantation also for patients lacking a matched family donor. And we need to improve our results with alternative donors. Especially we need to decrease the graft loss, the risk of graft rejection and of graft loss. So we can consider a matched sibling donor transplant as a standard of care procedure for children affected by sickle cell anemia. We now have transplanted more than 1,000 patients, and mostly children. And as I said, the disease-free survival reported in the literature is at least 90%. We have a rejection rate that is very, very, very low, and also the transplant-related mortality that is low. Age, in the context of matched sibling donor transplants, plays an important role. If we consider children transplanted when they are younger than 5 years of age, we have a 100% survival probability. But if we consider adolescents or young adults older than 15 years of age, the probability of survival decreases from 100% to 95% to 88%. So age is still important for the transplant of this disease. And we have some unmet needs. Outcomes are very good in children and in infants, but they are not so good in older patients. The majority of patients do not have a matched sibling donor, and it is difficult to find 10 out of 10 matched unrelated donors. So can an haploidentical transplant, so a transplant performed from a partially matched family donor, be a solution? Well, the answer is probably well, yes. This is one of the different studies published and the different experiences published in the most recent literature. This is a study of a cooperative group of Germany, London, and Paris. And as you can see, the approach is a little bit more complicated than a conventional transplant. We have to prepare our patients very carefully. They have to receive a hypertransfusion regimen for at least 2 months before the transplant. They must receive hydroxyurea at least for 2 months before the transplant, and in addition, they must receive also an immunosuppressive treatment before the transplant. The conditioning regimen includes several drugs such as tiotepa, fludarabine, antithymocyte globulin, and cyclophosphamide, and there is a specific immunosuppressive therapy after the transplant in order to prevent immunological complications after the transplant. Nevertheless, even if this approach is more complicated than a conventional transplant from an identical donor, the results on the first patient transplanted are very good, because we have in this series of 14 or 15 patients an overall survival of 100%, and in event-free survival. Event-free survival is survival disease-free, so without signs or symptoms of sickle cell anemia, that is in the order of 95%. So the transplant using a partially matched family donor is feasible. This is another experience with a slightly different approach. Again, we have 14 patients transplanted from a partially matched family donor compared to patients transplanted with a matched sibling, and the continuous line is the curve of the mismatched, the partially matched donors, and the dotted line that of the matched transplant. And as you can see, the probability of survival is identical, as well as that of survival without disease and of other complications. So an approach like this is certainly feasible, and with the results that are comparable to that of to those of transplant from a matched donors. And there is also a prospective study on stem cell transplantation using a partially matched family donor that is currently running in Europe. In this case, the approach is a little bit different. We use a selection of the stem cells before the transplant. That means that we collect the stem cell from the donor. We physically remove from the stem cells of the donor some subtypes of cells that can give immunological complications after the transplant, such as graft-versus-host disease, and the infusion consists of infusion of a purified stem cells, and this approach is effective too. Even we have this 24 patients out of 24 patients that have a full engraftment, that have a complete donor chimerism without or with a very, very low incidence of immunological complication after the transplant, and can be considered as cured from the disease. So this is my last slide. Allogeneic stem cell transplantation is a procedure that is effective in curing patients affected by sickle cell anemia. Currently we have different strategies. We have the possibility to perform the transplant from a matched sibling donor, and this is the most conventional transplant, and in my view, this type of transplant should be performed very early, if possible, within 5 years of age of the patient, and certainly before 10 years of age of the patient, because in very young children, this is the approach that gives the best probability of success, or more than 95%. But for patients lacking a matched sibling donor, we can start the search of a matched unrelated donor, and the results of a transplant with this type of donor, if the donor is 100% matched, are similar to those of a transplant from a sibling donor, from a matched sibling donor. The haploidentical transplant, the transplant performed from a partially matched family donor, a parent or a partially matched brother, has become in the more recent years a very effective procedure. There are at least 2 or 3 different techniques that make this procedure feasible with very good results. We do have a big experience in haploidentical transplants for other diseases such as non-malignant disorders, and this approach of a transplant from a haploidentical donor has been demonstrated to be effective also in the setting of sickle cell anemia. Again, the age plays an important role. The transplant gives better results if it is performed in children or in adolescents. It can be performed also in adults, but the clinical course of the transplant can be more complicated. So as a physician involved in stem cell transplantation, as I can say, my experience and the experience of my colleagues is that either is feasible, and in my view, it should be proposed to children or adolescents. It can be performed also in adults, in experienced centers, but the best results can be achieved in younger patients. So, as shown in an experience presented before, we don't have to wait too much. Even if we don't have a matched sibling donor, the transplant can be done in different ways, also from partially matched family donor. And considering children, all children have a father or the mother then who can donate for them. So my suggestion is not to wait too much and to discuss the indication to the transplant with the physicians, with the physicians involved in the management of sickle cell anemia with the physicians involved in the stem cell transplantation, because the results can be very good if the transplant is performed in an experienced center that is used to perform transplant in sickle cell anemia. Thank you.